Now assess the range of motion of the patient's elbows.
I'll have you flex your
To
elbows.
test flexion and
your
extension,
hands all way
have
out
the
massage.
patient bend his elbows as much as he can, and then straighten
Extend your
them.
arms.
To check supination and
Now bring
pronation,
your
ask the
elbows
patient to flex his
this,
elbows at
palms
90
up,
degrees and turn his
and now
palms
turn your
up
hands over.
and then down.
Let's check your left elbow now.
Next, support the patient's forearm so that the elbow is flexed to about 70 degrees.
Problems with your
Inspect and palpate the elbow, including the extensor surface of the ulna and the olecranon process. Note any nodules, swelling, or tenderness. Palpate the groove between the lateral epicondyle and the olecranon for tenderness, swelling, or thickening. Finally, press on the lateral and medial epicondyles for tenderness. Avoid pressing on the sensitive ulnar nerve.
Good. Let's check your right elbow.
As you inspect and palpate the other elbow, compare findings. Now, with the patient lying down, inspect the patient's feet and ankles. Note any deformities, nodules, swelling, corns, or calluses.
Ankle.
With your thumbs, palpate the anterior surface of each ankle joint, noting any bogginess, swelling, or tenderness. Feel along the Achilles tendon for nodules and tenderness. Test for tenderness of the metatarsophalangeal joints by compressing the forefoot between your thumb and fingers. Evaluate each of these joints by palpating the metatarsal head in the sole of the foot and compressing the joint between your thumb and finger. To assess the range of motion of the feet and ankles, dorsiflex and plantarflex the foot at the ankle. Next, stabilize the ankle with one hand and grasp the heel with the other. Then invert the foot at the subtalar joint and evert it. Now stabilize the heel and invert the forefoot at the transverse tarsal joint and evert the forefoot. Finally, flex the toes on the metatarsophalangeal joints. There should be no limitation of movement or pain. Now assess the range of motion on the opposite side. Check range of motion in the patient's hands and wrists. Ask the patient to make a fist, extend and spread his fingers, flex his wrists,
Now extend them.
and extend them,
Now move your wrist
and
to
move
the
his
side.
hands laterally
And now toward the center.
and medially.
Now let's look at your hands.
Inspect the patient's hands and wrists, noting any swelling, redness, nodules, deformities, or muscular atrophy.
Now let's check each finger.
Now palpate the medial and lateral aspects of each interphalangeal joint between your thumb and index finger, noting any swelling, bogginess, bony enlargement, or tenderness.
Good.
To detect joint fluid more easily, feel for it with one hand while using the other hand to compress the joint antero-posteriorly. To detect tenderness in the metacarpophalangeal joints, squeeze the patient's hand between your thumb and fingers.
Okay.
Then examine each metacarpophalangeal joint. Place your thumbs just distal to the knuckle on each side of the extensor tendon. Your fingers should be on the head of the metacarpal in the palm. Note any tenderness, swelling, or bogginess. Next, palpate each wrist joint with your thumbs on the dorsum of the wrist and your fingers beneath it. Begin the exam by assessing the temporomandibular joint. Place the tip of your index finger in front of the tragus of each ear.
And open and close your mouth.
Then ask the patient to open his mouth.
Good.
Observe the movement of the jaw, feel for swelling, and note any tenderness or
Very
crepitus. Next, inspect the neck, including the sternomastoid muscles, for symmetry, deformities, or abnormal posture.
Now let's check your neck.
Then palpate the spinous processes of the cervical spine.
And the muscles of your shoulders.
As well as the trapezius muscles
Good.
and the muscles between the scapulae. Identify any areas of tenderness. Now, test
let's check
range of
flexion
motion of the neck.
I'll have you
To
touch
test
your chin to
flexion,
your chest.
have the patient touch his chin to his chest.
Your chin to your right shoulder.
To check rotation, have him turn his chin toward his right
Now
shoulder
to your left shoulder.
and then his left shoulder.
Now bend your head towards your right
For
shoulder.
lateral bending, ask him to bend his head toward his right shoulder
And towards your left shoulder.
and toward his left shoulder.
And finally, tilt your head back.
For extension, ask him to tilt his head back. Note any limitations in range of motion. Assess the
Pull it up to
patient's
your
hips,
chest.
beginning with hip
Keep the other
mobility.
leg on the table.
Ask the patient to bend his knee to his chest, pulling it firmly against his abdomen.
Now
He
do
should
the
be
same
able to
thing with
flex
the
his
other leg.
knee and hip without difficulty while the opposite thigh remains near the table.
Very good. Now let's check other movements at your
Next,
hips.
test hip rotation. Flex the leg to 90 degrees at the hip and knee. Then stabilize the thigh with one hand and grasp the ankle with the other. Now move the lower leg medially so that the femur rotates externally at the hip. Then move the lower leg laterally so that the femur rotates internally. Finally, abduct the extended leg until you feel the anterior superior iliac spine move in the opposite hip. Repeat these maneuvers on the opposite
Now
side.
check on the other side.
Okay.
If a hip is painful or limited in motion, palpate for tenderness in 3 areas. First, palpate deeply below the inguinal ligament and lateral to the femoral pulse for the hip joint and the overlying iliopectineal bursa. Second, with the patient
No
lying on his
tenderness there.
non-painful side, palpate the greater trochanter of the femur
about now?
for the trochanteric bursa.
That's fine.
And third, palpate the ischial tuberosity for the ischial bursa.
How about any?
Finally, have the patient stand and again inspect his feet and knees, noting any deformities.
Okay, good. I'll have you turn around and we'll look at the back of your knees now.
As the patient turns around, observe for any swelling in the popliteal spaces. Inspect the patient's knees, noting their alignment and any deformities. Note atrophy of the quadriceps muscles or loss of the normal hollows around the patella. Then palpate the suprapatellar pouch on each side of the quadriceps, noting any thickening, swelling, or tenderness. Also palpate along each side of the patella. Identify any thickening, swelling, or increased warmth. Repeat on the other side. If you suspect a small amount of fluid in the knee, look for a bulge sign. First, milk the medial aspect of the knee firmly upward with the ball of your hand to displace any fluid. Next, press or tap the knee just behind the lateral margin of the patella. Watch for a bulge of returning fluid into the hollow medial to the patella. None is seen here. In another patient, there is a positive bulge sign. If you suspect a larger amount of fluid in the knee, check for a balloon sign. To do so, rest the thumb and index finger of your right hand on each side of the patella. With your left hand, compress the suprapatellar pouch back against the femur. Feel for fluid entering the spaces under your right thumb and finger. If you feel it, a balloon sign is present. If fluid is felt, Press the patella backward against the femur with your right hand, as your left hand feels for fluid returning to the suprapatellar pouch. A palpable return of fluid confirms a balloon sign. None is felt here. If the patient has a history of knee pain, compress the patella and move it against the underlying femur. Then push the patella distally and ask the patient to tighten the knee against the table. Pain and crepitus suggest a patellofemoral disorder. Now flex the patient's leg at the knee to about 90 degrees. With your thumbs, press into the tibiofemoral joint on each side of the patellar tendon.
How's that there?
Feel along the tibial margins. Tenderness from a damaged meniscus may be present here. Then palpate along the course of the collateral ligaments, laterally and medially.
Okay, good. Let's try the other leg now.
To evaluate the range of motion of the shoulders and related structures, assess flexion by asking the patient to raise both arms to a vertical position. Assess external rotation by having him place his hands behind his neck with his elbows out to the sides. Check internal rotation by having him place his hands behind the small of his back. If you suspect a problem, cup your hand over the patient's shoulders and feel for crepitus as the patient repeats the movements. Then inspect the anterior shoulders and shoulder girdles for symmetry, noting any atrophy, swelling, or deformity.
Now let's check the joints of your shoulder.
Palpate for tenderness at the sternoclavicular joint, the acromioclavicular joint, the subacromial area.
Any tenderness in there?
Mm-mm.
And the long head of the biceps tendon. Inspect the spinal profile, observing the normal cervical, thoracic, and lumbar curves. Also, inspect the spine for lateral curvatures. There should be none. Next, ask the patient to bend forward and touch his toes. A lateral curvature may become more evident with this movement. Then watch as the patient bends forward again. The normally concave lumbar curve should flatten out. Now sit behind the patient and stabilize his pelvis with your hands. To assess lateral bending, have the patient bend to the right.
Good. And now your left.
And left.
As far as you can. Now bend back.
To check
toward me.
extension, ask him to bend back toward you.
Fine.
And to assess rotation,
twist your right
have him
shoulder
twist his
forward.
shoulders to the right
And your left.
and to the left. These movements should be symmetrical and done with ease.
Okay, now if you'll rest both hands on the table, I'll feel along your spine.
All right.
And you let me know if you feel any tenderness.
Sure.
Finally, palpate the spinous processes for tenderness. And the paravertebral muscles for tenderness and spasm.
How about in the muscles here? Do you feel any tenderness?
No, it feels all right.
General musculoskeletal exam. The patient should be gowned or loosely dressed for the musculoskeletal exam. Begin each section with inspection for asymmetry, deformity, and atrophy, and identify the 6 cardinal signs of musculoskeletal disease: pain, redness, swelling, warmth, deformity, and loss of function. As with all sections of the musculoskeletal exam, begin with inspection. Then, palpate over each spinous process in the cervical spine. Next, palpate over the paraspinous muscle groups. Now, being careful to isolate each axis, test the range of motion in 6 axes: flexion, extension, right lateral flexion, left lateral flexion, right lateral rotation, and left lateral rotation. Begin examining the shoulder by inspecting for asymmetry, deformity, and atrophy. Lower the patient's gown to clearly inspect the joints. Always compare each joint and muscle group bilaterally. Next, palpate the shoulder beginning with the clavicle, the acromioclavicular joint, the coracoid process, and palpate the scapula, including the medial, lateral, and superior borders, the inferior angle, and the spine of the scapula. Also palpate the glenohumeral joint and the long head of the biceps. Now, with the patient's shoulders visible, ask him or her to stand up and demonstrate active range of motion in 6 axes. Always compare bilaterally. Make sure the patient crosses the midline when abducting and adducting. Then, with your hand over the joint to feel for crepitus, dislocation, or abnormal movement, perform range of motion in 6 axes again, this time passively. Again, compare each axis bilaterally. To examine the hand, first inspect the wrist and interphalangeal joints for swelling or clubbing. Compare side to side. Then, palpate the 8 bones of the wrist and distal radius and ulna. Continue to palpate the thumb and each finger on the metacarpophalangeal joint, the proximal interphalangeal joint, or PIP, and the distal interphalangeal joint, or DIP. Perform active range of motion of the wrist, isolating each axis. Then perform passive range of motion, while feeling the joint. Continue performing active, then passive range of motion in each axis for the thumb and fingers. Make sure to test abduction and opposition of the thumb. Remember to compare each hand bilaterally. Loosen the gown for optimal access and view of the back. Inspect for asymmetry, deformity, and atrophy. Then palpate each spinous process in the thoracic and lumbar spine down to the sacroiliac joint. Also palpate the paraspinous muscle group on either side of the spine. Be sure to palpate the sacroiliac joint as well and note any tenderness. Ask the patient to stand up. With the back muscles and spine visible, perform active range of motion in 6 axes. Keeping the hips stabilized, ask the patient to flex and inspect the curvature of the spine. Extend. Laterally flex. And laterally rotate. Begin the knee exam by inspecting for the 6 cardinal signs of musculoskeletal disease. Then, palpate the distal femur and quadriceps. Palpate the medial and lateral joint lines. It may be helpful to move the joint while palpating for these to make sure you are in the correct location. Palpate the patella and the patellar tendon. Also, observe and feel the patella while flexing and extending the knee. Palpate the tibial tubercle. The head of the fibula, and the popliteal fossa. Strength testing against resistance is included in the neurologic exam and a focused neuromuscular exam. While providing resistance, ask the patient to abduct the shoulder, flex the elbow, extend the elbow, spread their fingers, and oppose their thumb. Always compare strength from side to side. Ask the patient to flex his or her hips. They may do this one side at a time to brace themselves. Flex and extend the knee, dorsiflex and plantar flex the ankle. The drop arm test assesses function of the rotator cuff. Ask the patient to slowly raise his or her arm to 90 degrees, hold it for a few seconds, and then slowly lower their arms to their side. If the rotator cuff is injured, the patient will have difficulty holding their arm at 90 degrees, or their arm may drop suddenly around 30 to 60 degrees. This tests for impingement of the rotator cuff against the acromion. Abduct the patient's shoulder passively. If pain is felt as the arm is raised, especially around 90 degrees, the test is positive. Impingement is commonly found in patients with chronic rotator cuff injury. The anatomical snuff box is found between the abductor and extensor muscle tendons of the thumb. Press firmly into the depression. Tenderness over the snuff box indicates a scaphoid fracture. To assess the integrity of the flexor digitorum superficialis tendon, hold the metacarpal phalangeal joint still to isolate movement of the proximal interphalangeal joint. Ask the patient to flex and extend his or her finger. To assess the integrity of the flexor digitorum profundus tendon, hold the metacarpophalangeal and proximal interphalangeal joints in place. Once the distal interphalangeal joint is isolated, ask the patient to flex and extend his or her finger. This test is done if a patient complains of lower back pain. With the patient's leg straight, raise the leg until pain occurs and then dorsiflex the foot. Increased pain down the L5 or S1 distribution suggests compressed nerve roots. Repeat on the other side. This test distinguishes hip pain from spine problems. Place the patient's foot on the affected side on the opposite knee. Place one hand on the patient's knee and the other on the opposite hip, and press down gently. Pain in the sacroiliac area suggests a problem with the sacroiliac joints rather than the spine. Repeat on the other hip. To test the integrity of the collateral ligaments, raise the patient's leg with the knee flexed approximately 15 degrees. Use one hand to brace the thigh, while the other hand firmly pushes the leg in the medial and then lateral direction. Make sure you are attempting to slide the leg rather than bending it laterally. Watch for the tibia to dislocate from the femur in one direction. To test the integrity of the anterior cruciate ligament and the posterior cruciate ligament, hold up the patient's leg with the knee flexed at 30 degrees. With one hand bracing the thigh, attempt to slide the leg forwards and then backwards. Look for any displacement. Make sure you are sliding and not bending the knee. The drawer test is another method for testing the ACL and PCL. Have the patient rest their foot on the table with their knee flexed at 90 degrees. Sit on the foot to brace the leg. With your thumbs over the joint lines of the knee, pull forward and then push backwards, looking and feeling for any displacement. To test for fluid in the knee, use one hand to firmly milk down the thigh and suprapatellar pouch. Still applying pressure, place the fingers of that hand over the medial aspect of the knee. Then firmly and smartly push on the lateral knee with your other hand and feel for any fluid waves that travel medially. To test for a minor effusion in the knee, use one hand to apply pressure over the suprapatellar pouch. Push the patella sharply against the femur with your other hand. Look and feel for fluid returning to the suprapatellar pouch. This is commonly called the palatable knee test.
This video presents an examination of the musculoskeletal system, including inspection, palpation, and range of motion tests of the head and neck, hands, wrists, elbows, shoulders and related structures, feet, ankles, knees and hips, and spine. In this video, the examiner will assess a healthy patient. Keep in mind that other patients may have the same normal findings or may exhibit normal variations or abnormal findings. The extent of the musculoskeletal examination depends on the patient's condition and symptoms. As you examine the patient, ask him to report any tenderness and be alert to facial signs of distress.
Trendelenburg gait. During the stance phase of the gait cycle, the gluteus medius works to maintain both hips at the same level. What is Trendelenburg gait? Trendelenburg gait is an abnormal gait that is usually found in people with weak abductor muscles of the hip, which are supplied by the superior gluteal nerve. Here you can see a patient example of Trendelenburg gait. The patient could not abduct the right hip due to weakness of the abductor muscles on the right side. If the patient has weakness on the one side of the pelvis, and when the patient stands on that side, the pelvis on the contralateral side will drop. This is called the Trendelenburg sign. The gluteus medius is very important during the stance phase of the gait cycle in order to maintain both hips at the same level. The stance phase accounts for about 60% of the gait cycle. 3 times the body weight is transmitted to the hip joint. The hip abductor actions account for 2/3 of the body weight. We identify the weakness stance phase if the pelvis drops to the opposite side. Here you can see an example of weakness of the abductor muscle, as well as avulsion of the abductor muscle tendon. Weakness can also occur in patients with L5 radiculopathy or avulsion of the abductor muscle tendon, which occurs with increasing frequency after hip replacement surgery. The superior gluteal nerve injury is a major factor in this gait. A positive Trendelenburg sign occurs when there is dysfunction of the adductor muscles and the body is unable to maintain the center of gravity on the side of the stance leg. The patient will show an excessive lateral lean to keep the center of gravity over the stance leg. Here you can see an example of a normal gait, a Trendelenburg gait, and the compensated Trendelenburg gait. With bilateral weakness of the abductor muscles, the patient will have dropping of the pelvis on both sides during walking, which leads to a waddling motion. This gait is seen in patients with myopathies.
This video is for educational purposes only. Please consult your doctor before you make any decision about your medical care.
Just gonna film you walk if that's okay, just for educational purposes. No, it's good.
Teaching aid.
Yeah.
Yeah, there's a difference.